As we're waiting to get started, please answer the poll questions that are up. So we have a little variety in percentage of practices treating venous and leg ulcers. And seems like about 25% of people, or 40% of people are referring about a quarter of their patients to a lymphedema therapist. So I want to welcome everybody to this event. You go back a slide. So we're talking about today on lymphedema therapy basics and why you should care. And you can see here a quote from Socrates, actually Socrates in Greek. So for whoever is on the call doesn't know me, my background is Greek. And it says here, you don't know what you don't know. But actually what Socrates did say is, all I know is that I know nothing. And I don't know how many people know the story behind this quote, but it really comes from Socrates when he found out from a friend of his, when his friend went to the oracle at Delphi and asked if Socrates was the wisest man of all. And the Delphi actually confirmed that. So when he heard this from his friend, he was kind of confused because really Socrates was pretty humble and he knew consciously that in fact he was not that wise at all. But he also knew that the oracle really was the voice of God and really they spoke the truth. So he was kind of puzzled. So he went around town in Athens and actually he went to the politicians, ironically in our day and age, with all the political stuff that's going on. And he was asking them who thought they were actually the wisest people. And everybody around them actually believed it. But he was asking them questions and many times challenging them. They did not know the answers to these questions. So they got angry at him and really ostracized him. So he realized that really the wisest people are those who really recognize they don't know everything. And this is how this presentation came about, because I was speaking with the education department here in Tactile Medical. And I really said, you know, as physicians who treat patients with venous disease and leg ulcers, we send patients for lymphedema therapy or even using a lymphedema pump. And a lot of times, even myself, I admit, don't really know what is involved in the treatment of these patients, the basic lymphedema therapy. So this kind of triggered this educational program today. This is going to be kind of some basic stuff, and I'd like to make sure, you know, the lymphedema therapists that are on this call are not offended if we kind of go over the more complex and not really cover that, because it's really intended for the physicians or those who don't really know what is involved with lymphedema therapy for patients, and help actually take care of your patients easier. So there's two presentations today. The first presentation is Dr. Marlon Mellon, who is going to be talking about on physicians' slow thinking pathway to lymphedema and phlebital lymphedema. And then the second presentation is Julie Green and Susan Ellenson, who's going to give us a little bit more in-depth discussion on what's involved in lymphedema therapy. So Marlon, if you want to kick off for us. Mark, sorry.
No, you're good. You're good. Let's see, share screen. Excuse my technical abilities here. We're going to get it going in just 2 seconds. I'm going to show you, here we go. So, you know, Tony just described me to a T, because I'm the classic surgeon trained in 97. I graduated from general vascular surgery. I'm no longer performing arterial surgery. And, you know, as surgeons, I think we tend not to have a great air of humility. And I'm sure that gets a lot of people to laugh. This is my declaration page, by the way. And I've got a son who right now is in third year medical school at the Medical College of Wisconsin. And Isaac got about 30 minutes of lymphatic and venous education. It was all based on 1896 principles from the dog lab in Starling at Guy's Hospital. And he got the same education I did. And if you look at this over the course of time, you'd think we'd get to the point where there's now been this renaissance of lymphatic education and research that we're going to talk about. But I think a big error of being able to advance the science is a huge component of humility, because we've got to be able to be vulnerable and look at ourselves and say, you know what? I don't know it all. The field's changing rapidly. I don't have time to consume the volume of things that are published. And we did a book club at my house here a couple months ago. And the book we did was Thinking Fast and Slow by Daniel Kahneman. I'm sure many of you have read this, but ultimately the thing to pay attention to is this is a creative work that helps public understanding of topics such as behavioral science, engineering, and medicine. Well, when it comes down to it, medicine has a huge component of behavioral science as well as a huge component of engineering. So it really got me to thinking about what's fast food, what's slow food. Of course, we all know fast food isn't good for you. Fast thinking oftentimes gets us in trouble. And sometimes if we're going to reshift our clinical understandings, we've got to go back and really think through things and think slowly. So let's see, just need to advance my screen here, mouse. There we go. So there's going to be 3 principles we're going to talk about that are direct quotes from this book. First one is, our comforting conviction that the world makes sense rests on a secure foundation. And that's our almost unlimited ability to ignore our own ignorance. It's almost paraphrasing what Socrates had to say. Second is, a reliable way to make people believe in falsehoods is frequent repetition, because familiarity is not easily distinguished from the truth. And I think we've all seen this happen many, many times during our medical career. And just like diuretics work for swelling, well, we've heard that since we were trained. We know, in fact, that isn't truly applicable anymore. So if you look at again, the medical students being taught the dogma from 1896, well, that changed significantly in 2010 with Levick, Mortimer, publication by Dr. Roxon in 2014, and Levick and Michael were really the ones that instituted this out of England. What they found was that Starling's assertion of working in the dog lab that 80 to 90% of fluid moves back into the venous circulation from the arterial circulation, and essentially 10 to 20 goes into lymphatics. So therefore, why care about lymphatics? We have to focus on venous, and this is where the whole the dogma came out. If you give diuretics, it gets back into the venous system and you're going to get rid of it that way. It simply doesn't work that way. So we're going to start with our first polling question here. Which of the following describes a modern view of interstitial fluid homeostasis during venous hypertension? Choices are: increased venous absorption prevents swelling, increased lymphatic uptake prevents swelling, or, does it really matter? Lasix is the solution for all patients with swelling. And it looks like about 73% of people said increased lymphatic uptake prevents swelling. So clearly we have an educated audience here. I'm trying to find a way to click out of, there we go, thank you. So I'm the guy, again, that until I saw a buffalo hump, a stemmer sign, ulceration, I wasn't connecting lymphatic dysfunction, whereas we now know that lymphatic dysfunction is associated even as early now as C3, and there was just a paper that's in preprint from Journal of Vascular Surgery with Nearfly that shows even some C2 patients have lymphatic dysfunction. So by definition, if we're seeing these significant skin changes, chronic edema, it is lymphatic dysfunction, and it's something that we clearly have to pay attention to, especially now in wound clinics. We have to pay attention to the C4, the C5, and the C6s if we're going to accelerate healing and if we're going to decrease recidivism rates. And Wade Farrell, just such a humble guy, and just really changed our concepts of how we treat people in the wound clinic, especially with development of the Farrell wrap, the inelastic wrap. And he commented, phlebolymphedema was a very uncommon, underdiagnosed, and undertreated problem in the wound clinic. This paper was in 2010. We continue to be in this state in wound clinics throughout the United States, where we are vastly underdiagnosing and undertreating problems in wound care. And I just saw an article that came out in the September Wound Central Journal that, again, discusses that. Steve Dean spent, I think, a good 3-4 years of his life at the Ohio State putting together this data. And this is it's going to become a classic paper because, again, it points out in a way that no other paper has done. And this was just published this month in Journal of Vascular Surgery and Venous Lymphatic Disease. 440 adults referred for lymphatic physiotherapy. Now, this is a tertiary center of referral where you see a lot of cancer patients. So you'd expect, like we all thought, cancer would be the number one. In fact, what Steve, and he works with such a collaborative relationship with the multiple certified lymphedema therapists to get this data, it was chronic venous insufficiency was the primary driver. So it was about 42%. Cancer related was about 34%, 12% was primary lymphedema, and 12% was lipedema. So the big take-home message from this is chronic venous insufficiency, not cancer-related therapy, may in fact be the most dominant cause of lower extremity secondary lymphedema in the United States. The interesting thing in table 3 that I cut and pasted out of here was the total number of knee arthroplasty-associated lower extremity edema. And we see this, we've all seen this. Patients that had no post-op complications, no bleeding, no cellulitis, and they're coming to us 3-4 years later going, why is my leg still swelling after this perfect incision that never had a complication? And, you know, in talking about this, it could be impact of the ventral medial bundle, which is the main lymphatic pathway out of the leg. I think this still has to be discerned, but I think this is a significant thing to remember when we're seeing patients. The glycocalyx is what changed everything. First recognized in 1966, and it's in a renaissance place just like lymphatic because it's intimately tied. The glycocalyx is present in all lymphatic vessels, arteries, and veins down to the 5 micron levels, about a third of your hair. Here's the importance of the glycocalyx. It's not just that it makes all fluids go back into the lymphatic system instead of the venous situation, it's that it improves endothelial function because it releases nitric oxide synthesis. Nitric oxide is what improves innate immunity, also causes vasodilatation, helps in wound healing. It decreases permeability, so we decrease edema if your glycocalyx is intact. It's a rheologic layer so that it helps prevent coagulation in microvascular vessels, and it decreases inflammation, so it prevents leukocyte adhesion. So we all know about the white blood cell cuff theory in venous hypertension. This is it. When you have venous hypertension, and this was proven in an Annals of Vascular Surgery journal published 2018 out of Portugal, chronic venous hypertension sheds your glycocalyx, your white blood cells demarginate, and then you end up with all the chronic damage. Here from Hans Vink, who's trained in the US, is now over in Amsterdam running just a world-class glycocalyx lab, but you can see the fine hairs. And again, this is about 500 microns in terms of thickness. So very thin. It's an Amazonian forest of complexity with many different things. You know, Ebong's lab over at Northeastern in Boston has done some excellent work as well. And the components of this, so again, back to the rheologic point, heparin sulfate, albumin, chondroitin sulfate, hyaluronic acid. Well, hyaluronic acid is the impermeability part of this layer. In the 60,000 miles, this is what helps decrease swelling. And if you look at figure D, the analogy is, think of your lawn and the grass. So the glycocalyx thickness is like the grass on top of the dirt. If you lose the lawn, you expose the dirt dries up, and it doesn't sustain, it's not viable anymore. An active glycocalyx maintains endothelial cell health. That's where the nitric oxide is produced, as well as other types of cytokines and other things that maintain healthy vasculature. So this is, the glycocalyx is what resulted in the revised Starling law that we now know, definitively proven starting 1997 moving forward with the classic paper published in 2010, that helps maintain all the interstitial fluid going into the lymphatics. It cannot reabsorb into the veins. Here's poll question number 2. Which clinical findings lead you to diagnose lymphedema? So chronic edema with skin changes, positive stemmer sign, any of the above, or just B and C. And again, I was the guy, I wasn't picking up on until late, just until recently. So I'll tell you, in spending time reading and thinking about this, again, thinking slow, you can change your thought pattern and pick up on this diagnosis much earlier in your clinics.
So Mark, how much do you rely on the stemmer sign to diagnose patients with
I think it's a part of the constellation. It's interesting because if I see people that have really swollen legs but no stemmer sign, first thing I'm thinking about is lipedema. And then if they still have that classic body habit is they tell me, well, I lose all this weight, but it's only on my torso, I can't lose it on my legs, and they have a stemmer sign, then to Steve Dean's point, you're thinking, well, it's lymphedema. So I think the stemmer sign's important, but it's not the end all for me.
I think, if it's present, it gives you definitely a telltale sign that there is lymphedema involved. But if it's absent, it doesn't necessarily, rule it out, especially when it comes to phlebital lymphedema. I think a lot of those patients, at least in my practice, I don't have a stemmer sign with, phlebital lymphedema.
Excellent point. Let's see, I'm just trying to hit that close button again. And I apologize, there we go, thank you. The slide I just passed correlates with this slide. So the slide that I just passed was a Carolyn Fife and Rasmussen study that was published in 2010 that looked at manual lymphatic drainage using indocyanine green, and it's proving that when you do manual lymphatic drainage on the foot, you activate lymphangions throughout the leg. This goes back to if you increase shear force in the lymphatics and activate the glycocalyx, you'll release nitric oxide. The nitric oxide is what causes the lymphangions to contract. So there's a body of thought that says once lymphangions are gone and fibrosed, they'll never come back. We know, and this is a study that we're looking at now, here we've got this chronic venous stasis. This is obviously a C6, the gal below is a C4. And if you go by that reasoning, these lymphangions should not work. Yet when they applied pneumatic compression on these patients, you actually see lymphatic functioning. So clearly there is the ability to resurrect lymphatics through careful, maintained treatment. So this is where our CLTs, our certified lymphedema therapists, are so critical, because lymphatics at the end of the day, they're gritty, they have resilience, they have great perseverance, and they can be rescued. And it's the appropriate treatment. So an MLD-like approach in treatment with a pneumatic pump is really what gets us our great outcomes in peer-reviewed literature. So 2 last slides here. Conclusions: venous and lymphatic anatomy and disease states are well undertaught as a part of a current medical school education. The recognition of the glycocalyx has resulted in the revision of the dogmatic 1896 Starling principle. 100% or near 100% of lymphatic fluid actually returns to the lymphatic system, not through the venous circulation. All chronic edema indicates to some degree inadequacy of lymphatic drainage. The near-infrared fluorescence imaging, or NIRFLY, demonstrates that chronic lymphatic dysfunction in the C3 and C6, and we're going to see more data shown even in the C2, applies in the clinical venous classifications. Lymphatic dysfunction and phlebital lymphedema are associated with increased risk of cellulitis, chronic inflammation, and progressive lymphatic damage. And I'm just going to say one thing about phlebital lymphedema. I'd like to start calling it lymphedema of venous etiology, phlebital lymphedema, so that we make sure and emphasize that lymphatic component. Venous leg ulcers and cellulitis are clearly associated with increased rates of hospitalization, outpatient care, medical resource utilization, as well as increased recidivism rates. And clearly, the more vulnerable we are to go back and learn this and think about these principles and apply them on a daily basis in our clinics, we're going to identify earlier, and we're going to treat phlebital lymphedema way upstream. That means that ideally we should be able to lower the number of C6 and C5 patients, less ulcerations, less recidivism. And this clearly goes hand in hand with working with our certified lymphedema therapists. So we have good complex decongestive physiotherapy as well as manual lymphatic drainage. So ultimately, a lymphedema pump should always go with ordering a certified lymphedema therapist. Last principle and last slide. You know you have made a theoretical advance when you can no longer reconstruct why you failed for so long to see the obvious. And I love this mantra because it just reminds me every day, I can improve. And, I got 10, 15 years left in my career, and I hope every day I'm making some advances in treating patients. Thank you, Tony.
Thank you, Mark. Let's see, any questions from the audience? No. Mark, you take care of patients with venous disease and run a wound clinic. How often after treating, let's say, superficial problem, do you have patients that come, with persistent leg swelling, despite treating their superficial disease?
Well, I think we see a skewed population because everybody that comes to us that's had superficial venous insufficiency ablated still has an issue, still has leg edema, still has an open ulceration that did not respond. So, I have to be careful in how I say this. So for us, it's 100%, but I know in fact that there are really, really good physicians out there doing phenomenal ablative work, treating perforators. So once you get to kind of a late C4B, C5, C6, you're not going to be able to ablate away that venous hypertension and get lymphatic functionality. It's past point. That's where it's so critical to pay attention to lymphatic dysfunction and get patients appropriate long-term care so that we have really good outcomes at a overall cost economic savings to healthcare facilities. And more importantly, it's what we want for our own family members.
Now, do you routinely, since a lot of these patients have either healed or active ulcer, do you routinely look at their deep venous system?
Yeah, absolutely. Because we're seeing such an epidemic, obviously, of increased BMIs, and the deep system, as you know, only in about 40% of patients, if you treat the multi-level superficial, are you going to have an impact on the deep system. So I think it's still important to pick up on deep venous insufficiency, especially where there's maybe an occlusive component, because we know insufficiency with occlusive component of previous deep venous thrombosis has the worst outcomes. And so I think it gives us a better chance to educate the patient and make some of these other lifestyle changes. And I think it's important to have that information.
Okay. I think we're going to move along, and Julie's up next.
Okay, well, thank you, Dr. Chris and Dr. Moline, for that great presentation, Dr. Moline. That was excellent information and introduction to this next section, which is really talking about lymphedema therapy. I'm excited to have doctors that are really interested in what we are doing with your patients and how we can help them, and just give you a little bit of insight as to what goes on in our clinics. I also know that there's quite a few lymphedema therapists on here, and so I would ask that you refrain from really answering or participating in any of the polls going forward, because we know that you'll know all of the answers, and we'd like to know what some of the physicians have to say. So we are going to talk about lymphedema therapy. So typically an OT or PT is the discipline that becomes certified with advanced treatment and management of chronic edema. You can see here there's several schools that are available throughout the country that provide that certification. And it is relatively new though. So it was only around 40 years ago that the first specialized clinic opened in Hinterzarten, Germany, and that was the Foldy Clinic. I'm sure most of you are familiar with that. And since then, several have emerged in this country as well as others, and there's new ones coming, popping up all the time.
Julie, when in training for PTOT, what percentage, I mean, we talked about in medical school, you get 30 minutes of lymphedema education or lymphatic education. How much does a physical therapist spend to learn really lymphedema therapy?
So it's usually 147 to 150 hours of education and hands-on practical application with patients. And yeah, so looking at
better than medical school.
So thinking about how relatively new it is, I'm wondering if you know what year the first specialized lymphedema clinic opened in the US. Was it 1980, 1955, 1993, or 2001? And I'll just wait.
1980 was when I was born. No.
Young. So
I wish.
one would not be correct, but that would be a good answer. So really 1993 was the first specialized clinic opened in New Jersey and New York City. And just to really show you that, 30 years is not very long to really understand and learn about this treatment, and tells us really we have a long way to go to really educate and bring awareness. So lymphedema clinics really go through, as Dr. Moline said, complete decongestive therapy. There are two phases. The first phase is in clinic or acute care. And then we have a self-maintenance phase, which is lifetime. As we know, this is a chronic condition. The first phase is typically 2 to 4 weeks. It can be longer if the insurance permits it, or, really always depends on the patient, because it is a commitment. I mean, the patients are really asked to come 3 to 5 times a week. Sometimes you're there for 90 minutes each session, and it takes a lot. I mean, it depends on the patient's mobility, their transportation, their co-payments. So we really have to get them to buy in at that initial eval.
And is that 2 to 4 week duration of the in-clinic therapy that's approved by insurance, is that a one-time, or is it like annual, or?
I think that's probably annual. I'm not 100% sure, but oftentimes insurance will give a limit per year of number of visits they can come. So all schools really maybe have a different methodology, but they really focus on these 4 main components: manual lymph drainage, gradient compression bandaging, exercise, and patient education. So the manual lymph drainage is our main attraction tonight. We're going to be having a demonstration, and Sue is going to really talk through that, why we do it, how we do it, where we start, sequencing, strokes, and really what we're influencing. And it is really basically an advanced skin technique that stretches the skin to elicit increase in lymphatic vessel contraction. And we're able to move fluid around obstructed areas, around scars, maybe away from wounds, and move it out of the edematous region and into more normal, healthier regions where it can be absorbed normally. The gradient compression bandaging is a huge component, and it is really important that the CLT understands what the bandage system is, what the the skin integrity, the thickness, is it doughy, does this patient have really fragile skin? Because when they're bandaging, they're putting multiple layers on, and if they don't do it correctly, it can really be dangerous for the patient, especially if they don't know how to pat around bony prominences, or they don't know that they've used too aggressive of foam over areas that maybe were fragile and thin. So you really have to know what you're doing. It is a skill that takes some practice and some expertise. And we do recommend that you use short stretch bandages for this. So this patient in the lower left corner probably has, I don't know, maybe eight bandages layered one on top of the other. And we also have to know how to pad it around lobules and misshapen legs so that you still get that gradient to elicit that muscle pump, which really goes into the exercise. So this phase of treatment, obviously everyone should be exercising more, especially patients that have lymphedema if they're able to, but it's really important here because this is where we can make some headway into getting huge volume reductions, really softening the tissues, improving oxygen to the superficial lymphatics. And then education is ongoing. So education is, we have hours and hours and hours with these patients. So we really walk through what lymphedema is, what the progression is, the risk factors for infection, how can they avoid that, the importance of meticulous skin care, and on and on and on, really preparing them for this. And it really is a culmination of all those components of education and teaching to equip them with tools that make them successful at home. So the things that are really important for the patient to have at their ready is, number one, are they going to be bandaging their own leg? Do they have a caregiver to do it? Is this all ready for them at discharge? Do they need a DME, or do they have a pneumatic compression device ready for them when they're going to go home? Because we don't want to lose any ground. We've worked together really hard to reduce the size of this limb and improve the integrity of that tissue. And it can really all, go backwards or progress very quickly. So understanding also the severity of their disease, because do they need a night garment? Do they have rapid refill? Do they need a channeled foam garment that's really going to work on their progression? Are they able to really don their stockings? If not, do they have a Velcro strap binder? So there's a lot that goes into educating and teaching the patient to really be independent or with a caregiver. I really feel like this is where the medical community fails us, because it is a chronic disease, but we really treat it episodically. And so this patient needs follow-up. And if they can't get follow-up from the therapist, then they should really have that follow-up from the physician. So we can't talk about lymphatics without really talking about the initial lymphatic capillary, because this is a disease of the skin. And we as clinicians, as therapists anyway, this is where we can really influence the contraction rate of those lymphatic vessels. If you look at this left screen, the endothelial cells that are open, overlapping with the open junction, they're attached to the anchoring filaments within the interstitial tissue. And when that fills with fluid, that skin stretch that we provide creates a change in pressure, opens that junction, the fluid moves in and propels to the vessel, the actual lymphangion, which propels it further to the deeper vessels and to the trunks and the ducts. So normally a lymphatic vessel contracts around 6 to 10 times per minute, but we can really influence that with manual drainage, with a pneumatic compression device, stockings, exercise, and so forth. So when we think about when we're draining fluid from the initial superficial lymphatics, we move down into the deeper lymphatics. So we have 9 major trunks and we have 2 ducts. And when we're talking about draining the legs are really drained by the popliteal and then also the inguinal nodes, and then they take a deep dive and go up through the right and left lumbar trunks, and they meet with the intestinal trunk to form and drain into this thoracic duct in the middle, which is the largest duct in the body. And if you look over on the right, you see this image of blue, and that is the area, 3/4 of the body is the responsibility of the thoracic duct to drain. And knowing that as a therapist is really important, because we need to know where to move that fluid. The right upper quadrant is drained by the right lymphatic duct, and it's all drained together up at the right and left subclavian veins. So the second polling question is, when we talk about lymphatics, what is a lymphatic watershed? Is it a reservoir in the body that stores excess lymphatic fluid? Or is it, does it represent linear areas on the skin that separate lymphatic territories from each other? Is it lymph drainage into the right and left subclavian veins? Or is it regions of the body that receive dual blood supply from the most distal branches of 2 large arteries? And I'll just wait a bit. Oh, so most of you got this right, and that's awesome. I thought that a lot of the doctors were going to say number 4, because I took that right out of what I would think of as a medical watershed. But when we're talking about lymphatics, it's a linear area that divides and separates territories. So it divides it into basically these quadrants where the lymphatic fluid is drained to those regional nodes. And if you look at these lines on the body, you can see the sagittal divides it into the right and left, and the horizontal or transverse divides it from upper and lower, and anterior and posterior, inguinal and gluteal, as well as the upper horizontal. Now, as a therapist, if I'm working with a patient, I need to know all about that patient's history. And also I know where I'm moving it out from the limb that is edematous and needing help, but then where am I moving it? Across which watershed? For example, if a patient has breast cancer, I'm not gonna move it to the adjacent ipsilateral axillary region. I'm gonna move it across to perhaps the contralateral axillary region, or to the contralateral inguinal region. So we need to know where we're moving that fluid. So the next, So now we're going to move to the main attraction, and that is the demonstration of manual lymph drainage. So Sue is going to take over from here, and she's going to talk to you really a little bit more in depth about what goes on with manual drainage. But before we get there, I just want to ask one more question, and that is, who has observed a manual lymph drainage session? Have you? Yes, no, or are you unsure that perhaps you were watching an episode of it? So it looks like most of you have not. All right, thank you.
Okay, thank you, Julie. And I think that it's really great just to kind of have an idea of the anatomy and the physiology, because it does help explain why as therapists we're doing what we're doing. And we were anticipating that many of you have not observed a session. So again, I just hope this is a great demonstration, because it is really important to be able to understand what type of treatment you're referring your patient to, but also because the patients might have questions for you. And I know oftentimes as a clinician, I would have a patient come in and I would ask them, what are you here for? And they'd be kind of like, I'm not really sure. I only have a little bit of swelling. I had no idea that a therapist even did this. I thought you just, gave massages to the back, that type of thing. And I think that the more they understand what kind of treatment they're getting, and as a physician to be able to explain that to them so they know what to expect, the patients are certainly going to be more compliant as well. Before we get into the demonstration, another polling question here, but I just want to find out, as a provider, if you know where a therapist starts manual lymph drainage, regardless if it's upper or lower extremity treatment. Would you say it's the most edematous region, below the region of edema, the cervical region, or abdominal region?
This is a trick question, right, Susan?
It is a trick question.
I got it wrong the first time.
Okay, kind of a little bit of a mix there. So if you answered in the cervical region, you would be correct. And if you remember, Julie pointed out earlier, all lymphatic fluid ultimately drains or empties into the right lymphatic duct or the thoracic duct, which eventually dumps into the venous system at the subclavian vein there. So we'll be demonstrating that in our next session here as well. And like Julie said, a session can last about an hour, sometimes even 90 minutes if they have bilateral involvement. For today's purposes, we certainly won't have you sit through an hour demonstration. We're just going to be showing you short clips here that's really going to highlight kind of the sequencing that's used, the techniques, specific just to lower extremity management. Okay, so we're going to begin with the demonstration here. And just know that prior to treatment, the therapist is going to be giving consideration to the patient's medical history, the tolerances to positioning, and they're going to modify treatment as indicated or even reach out to you as a provider if they need any additional questions or clearance provided. But as stated, treatment for any MLD sequence always begins here at the cervical region or the terminus of your lymphatic system. And by starting here, we're really able just to decongest and open up that lymphatic pathway to prepare it to receive fluid from the more distal areas, which for this treatment is going to be the legs as well. And I think this is really important for patients to understand, as they're going to be confused, and rightly so. Why are we massaging their neck when it's their feet that are swollen? And a lot of patients will certainly ask you that. And during a therapy session, the therapist has the perfect opportunity to be educating your patients. I mean, they're literally in the palms of our hand for an hour. And I think, in the medical world today, that's really unusual to have a patient for that long to just be talking to them and educating them about their venous system, their lymphatic system, how they function, how fluid is being mobilized, and how they can treat edema. Because we need them to understand that this is chronic, it is progressive, it's lifelong management. But you also need to reassure them that it can be managed with proper treatment. And I think we can all just agree that the more the patient understands about their diagnosis and risk factors, if they're not properly managing them, they're going to buy into treatment more, which is just going to translate into increased patient compliance. So once the terminus has been cleared here, the therapist is then going to move to the abdominal region. And treatment in this area includes manual lymph drainage, but it also includes deep diaphragmatic breathing techniques. Sometimes you might spend an entire session trying to teach the patient how to do diaphragmatic breathing. But once they get that, you can see here the therapist is using different hand positions with pressure while the patient is performing deep diaphragmatic breathing. And this is really going to just stimulate those deeper lymphatic structures that Julie touched on previously to move that fluid from the legs up back to the terminus. So it's going to be the pelvic and lumbar lymph nodes, their lymph trunks that drain into the cisterna chyli, that moves into the thoracic duct, but also stimulates those organ structures with their lymphatic systems, like the lymphoid tissue of the spleen and the liver. And while the therapist is working in this area as well, they might also feel abdominal adhesions from prior surgeries. I'm sure many of your patients have undergone surgery like C-sections or maybe hysterectomies or hernia repair. And that's going to require just a little bit additional tissue work, as these adhesions can slow down or even sometimes block that lymphatic movement through this region. And then think about your obese patients, the deep pelvic veins that you were just talking about. They certainly are going to need some additional treatment time in this area as well, because it really can just optimize that lower extremity fluid reduction. And again, you're only seeing a short clip here of MLD to the abdominal region, but know that treatment to the abdomen can take up a good portion of the session, depending on the body habitus and the extent of their edema and adhesions. Now, if a patient's unable to tolerate manual lymph drainage directly to the lower extremities, either due to pain, maybe they just have some fragile skin, open draining wounds, a recent vein procedure that would be contraindicated, working proximally could still be very beneficial to stimulating the lymphatic drainage and just to help to draw that fluid up from the lower extremities. And if you're familiar with the FlexiTouch device, the trunk garment is designed in much the same way as you're seeing here to just really stimulate the lymphatic system of that abdominal region. So the therapist has now cleared the terminus and the abdominal region. What do you think is the next appropriate region that they're going to clear in order to drain the lower extremities? Would you say the inguinal region, the popliteal, the axilla, or the feet? Okay, inguinal, about 75%, and that makes sense. Let's head on south, right to the legs, right? But actually there's one more area that we're gonna wanna clear first. So if you answered axilla, you would be correct. And if you recall from Julie's prior slide when we talked about the lymphatic watersheds, the therapist is going to use manual techniques to manipulate that fluid across these watersheds from a congested region, which in this case is going to be the legs, into a healthy area with intact lymph nodes. So those lymph nodes can receive and process the excess fluid easily. So again, in the case of lower extremity lymphedema treatment, we're going to move the stagnated fluid across that transverse watershed that's kind of right at the waist there. And we're going to bring it up to the axillary lymph nodes so that they can take up that fluid to process it. So we're going to open up that region first. Once the cervical and the abdominal and the axillary region have all been cleared, we've now completed what we consider proximal preparation phase. And this region is really ready to receive fluid from the lower extremity. So with that, then we're going to move into the lower extremity treatment at that point. And we're going to start proximal on the leg as well. We're going to decongest this area prior to expanding the treatment to the more distal aspect of the leg. And really this segmented approach ensures that the lymph vessels located more proximately are properly prepared to handle that incoming lymphatic fluid located more distally. And you'll see oftentimes the therapist may spend a lot of additional time at the medial thigh, the popliteal region, as this is often an area pooling due to that bottleneck effect of that fluid trying to exit the legs. And you're going to see that in your patients, that bottleneck effect is they're going to have a lot of swelling around their knee oftentimes, in addition to those medial lobules. But as you observe the therapist techniques here, I really want to go into a little bit more detail about the common characteristics of manual lymph drainage. The therapist is using very purposeful skin techniques here at their hands to provide the desired effect. Depending on the anatomical structure, the size of the limb, the tissue type, the therapist is going to change their hand placement, the type of stroke that's used, the length of time spent in an area. And for many therapists, this just becomes intuitive. By touching the skin, we're going to be able to feel how deep do we need to go, what areas do we need to spend extra time on, how much pressure can we use, those types of things. But really, again, the overall common characteristics are similar in that it uses gentle pressure. And I don't even really like to use the word pressure. It's more of a skin stretch. It should not be deep. This is not a muscle massage as much as the patients would like that. You can refer back to that slide of the lymphatic capillary. The skin stretch is really going to change those pressures in the interstitial area. It's going to pull on those anchoring filaments, which is going to open up that lymphatic capillary to allow that interstitial fluid to enter these superficial capillaries. So another characteristic is that it has both a dynamic or a working phase, which is used to promote that fluid in the desired drainage direction, but it also has a relaxation or a resting phase, which results in a vacuum effect caused by that passive distension of the tissue, and it allows for that refilling of the lymphatic vessels. The other characteristics is very slow. Application of a stroke is about 1 to 3 seconds. Faster is not indicated or effective. As Julie had mentioned, a lymphangion pulsation is about 6 times per minute when resting and about 20 times per minute when actively working. So the FlexiTouch can simulate these same characteristics, provide self-automated manual lymph drainage in the home. The narrow chambers inflate and deflate at about 1 to 3 seconds, which is going to simulate that work and release phase of manual lymph drainage. And then this work and release mechanism stimulates those anchoring filaments, which opens up the lymphatic, superficial lymphatic capillaries to take up this fluid and mobilize it deeper into the lymphatic system for the body to be able to process this fluid. So in returning to the demonstration of manual lymph drainage of the lower extremity, the therapist has cleared out the thigh, they've cleared out the knee, they're going to move down now into the calf, down to the malleoli, which is also an area pooling, and eventually they're going to end up to the foot there where you know can be a lot of congestion in that area. Oftentimes the patients are going to need to have the toes addressed even, and we will work each of those toes. Once that's all completed, the therapist is then going to begin treatment to decongest the leg by moving fluid from the most distal aspect of the leg all the way back up to the terminus of the lymphatic system. I want to point out that you're not seeing things here. The therapist does not just magically start working faster. We've sped up the video here just to kind of show you the fluid is being moved back up to the terminus. She's using the same strokes, the same speed. But what is a little bit different is the therapist may, on their way back up, they're going to stop and they're going to rework any advanced tissue changes such as fibrosis and scarring. And the FlexiTouch can be used the same way as well, as it offers supplemental programs to provide that additional work or attention to the patient's problematic areas. But for a patient with chronic edema, manual lymph drainage really needs to be completed daily for optimal management. You know, these techniques can be really difficult for your patients to perform themselves, especially given the age of many of your patients. Many of them might have chronic back pain. They can't bend, they can't reach to their feet, their lower legs, they have impaired range of motion. For your very large or obese patients, you know, the pannus and the lobules, it's hard to bend, they're hard to lift. That's a lot of weight to be able to lift and massage. And again, it can be really challenging. So automated self-manual lymph drainage using advanced pneumatic compression can certainly successfully achieve this treatment for your patients in the home as well to manage long-term. So that does complete our demonstration of manual lymph drainage. And I hope, you know, at the end of this program, if you got some questions about it, I know both Julie and I would be more than happy to answer those questions for you, but I want to touch on just a couple things before we get there. And I know Dr. Moline and Dr. Gasparis were talking a little bit about the Stemmer sign, and it is considered positive and diagnostic for lymphedema when you cannot pinch or tint that tissue at the toe. And this can be a great clinical assessment tool to help in your diagnosis of lymphedema. But what about those patients that do have a negative Stemmer sign? So if you want to take a look at this patient here, right away you'd look at the foot and you'd say, there's no lymphedema there. Her tendons are present, the veins are prominent, and her Stemmer sign is negative. So with that assessment, can we completely rule out the diagnosis of lymphedema? So I would really encourage you with your patients, you know, you can't just visualize signs of lymphedema, nor can you just visualize signs of fibrosis. They might have fibrosis, but maybe not any other outwardly signs of discoloration or those types of things. So you really need to be moving up the leg, palpating the skin, stretching the skin. How does it feel to the contralateral side? how does it feel if both legs are involved, you know, assess the upper extremities even to see how their skin should be moving. But again, I just really encourage you to palpate the other areas. This is the same patient that I just showed you that had a negative sign. This is her unaffected leg. You can still squeeze and lift and tent that tissue pretty easily. If you look at her affected side, that she had the negative stemmers, you can see the difference in the tissue there. And I am really trying to squeeze it pretty hard. You can see kind of the whitening of her skin there. She actually does have a diagnosis of stage 2 lymphedema. Her legs even look pretty symmetrical. But again, you have to be assessing that skin with your hands, not just your eyes as well. So just a couple more slides here. And you might be asking yourself, you know, really when is a good time to refer a patient for lymphedema treatment? Well, I think the obvious one would be any patient with those clinical signs and symptoms of skin changes, you know, that Dr. Mark Moline was talking about before. A CEIF score of 4, you're going to start to see skin changes, and that is indicative at C4 that you already have mechanical lymphatic damage. Stage 2 lymphedema also with pitting edema, fibrosis. But really for any diagnosis of lymphedema, we want to be catching them before that in order to provide the best outcomes for them. So a CEIF score of 3, stage 1, when the edema is still reversible and prior to those skin changes, when the lymphatic system is still intact, it's just really being overwhelmed. By providing that intervention, again, we're going to be able to decrease that risk of progression and infections. But another great opportunity would be any complaints of aching, heavy legs without those outwardly signs of changes, as this certainly, as we know, is probably indicative of post-thrombotic syndrome. And again, addressing that lymphatic system early is going to prevent that further damage and that dual system failure of the veins and your lymphatic system. But I think as therapists, you know, Julie and I both really just want to stress that therapy can help with so much more than just the swelling of your patients. We can help to improve the mobility, their range of motion. That's really going to just assist with that calf pump and venous return. Or those patients who say they're not compliant with their compression, you know, it may not be that they're necessarily non-compliant, but they just physically can't adhere to treatment as they cannot manage the independence with getting that compression garment on and off. And we know that wearing compression is vital to their management. So as a therapist, we can assist them with, you know, improving their range of motion for improved mobility to bend and reach to get them on, but also provide them other tips and tricks and assistive tools to make them successful at home. And really just maximizing all their body systems, the lymphatic system, the musculoskeletal system, neural, circulatory systems, which is again, just really going to aid in your patient's success overall.
So Susan, when a patient comes in for MLD, do you guys routinely do physical therapy as overall for improving range of motion and
Absolutely. Yep. You know, we do assess the lymphatics, but I think through the course of their treatment with us, oftentimes I would have my patient out in the gym. You know, we'd be doing cardio and muscle pumping exercises, especially once we got the bandaging on them, stretch their heel cords. Oh, go ahead.
So as a physician, we don't necessarily have to request that type of physical therapy, or we do?
You know, if there's balance issues, gait mechanics, but you know, as a therapist, I think if we are understanding, we're looking at the body as a whole, and we know that, okay, their calf pump isn't working to move that fluid, we probably are going to be doing some stretching with them. Again, just education and exercise to be able to facilitate that calf pump and muscle pump to get that fluid moving. So it is a holistic approach. I mean, I think if you're doing eval and treat, you know, that will pretty much cover it all. With the diagnosis, you know, even though it's lymphedema, we can still be addressing these other body systems as well to make them independent.
Julie, do you want to add something?
I was just going to say, I think it, you know, depends on the time that we have as well. I mean, our focus is the edema, but we often incorporate, I kind of think about when my patient would come in, I would have them do the stretching to try and remove their bandage, also having me assist and facilitate, you know, safe stretching and try to get them to do things at home, set them up with some kind of a home program that will help them move forward with range of motion or balance or strength.
You know,
And I would say, Oh, I was just going to say, so often, the patient may come in with a diagnosis of lymphedema, but as you talk to them about their abilities to perform their ADLs, so often their legs are so heavy and they've been trying to lift them into the car or the bed that they have hip flexor tendonitis. I mean, that really limits their mobility, and you need to be able to address that too. So if it's a matter of a question of, the orders too, as a therapist, if it's something that we think is going to be well beyond just lymphedema management, we'll always reach out to the physician to get that additional orders if needed. But, you can't just make a clear separation of this is lymphedema, this is orthopedic, because they just tie into each other so much in relation to their abilities to perform their ADLs at home.
All right, and either Julie or Susan, we haven't really touched much about self-MLD, and I'm kind of curious, do you teach the patients to do pretty much everything from start to finish, like, when you do it yourself? Or is there an abbreviated version, or
I can speak.
massaging their axillas and
Mm-hmm.
supraclavicular area?
I mean, I'm a proponent for the advanced pneumatic compression, and I can tell you that I'm a lymphedema patient and the therapist, and I'm not able to do adequate self-MLD.
Mm-hmm.
In my opinion, and when I'm with patients, I really provide them with diaphragm breathing. Patients can easily clear their supraclavicular area and their axillary region, and utilize pneumatic compression because it's just impractical for them to do the entire session. I just think it's difficult for patients, and some do. I don't want to say that they don't, but I guess I'd leave that up to the patient, and I need to see that they could do it themselves before I would discharge them.
Mark, there was a question from one of the participants about any type of blood work or anything when you see a lymphedema patient that you do as far as the workup?
Great question. So I think we always have to look for other organ pathology. So is there any potential for congestive heart failure, liver issues? Certainly want to check a creatinine and a GFR. And I think it's so important to make sure those organs are functioning, because that certainly can be the cause, or certainly then contribute to if the patient has underlying lymphedema. From an imaging standpoint, I've seen too many of us look at a duplex ultrasound, back to your point earlier, Tony, that, well, the waveform in the groin looked just fine on duplex ultrasound. And they assume that proximal and the iliac then is perfectly fine. In fact, I just had a case like this last week. Asymmetric, large left leg compared to the right, had failed all standard of care. The surgeon I was working with said, I think it's fine, the waveform looks good. I said, I think we should get a CT scan. Well, sure enough, she had no left common iliac vein. She had a small external that communicated directly to the inferior vena cava, a separate internal, and her external iliac vein was only 8 millimeters. And she's had a history of a deep venous thrombosis, so there certainly could be a web in there. So we're going to get a intravenous ultrasound, an IVUS. So I think, especially in the left leg, where we may be concerned about May Thurner, the relationship between the left common iliac vein and the right iliac artery, or any other anatomy, we've seen sarcomas in these positions cause it. I think you got to look proximal if patients just aren't responding to standard of care.
Mm-hmm.
Because you don't want to order up a lymphedema pump on a patient's leg when you haven't corrected the actual problem. And I want to make just one last comment on the glycocalyx, because I think it's fascinating to watch the hands of Julie and Sue as they're treating patients. And if you really think about it, the glycocalyx has all these factors then that result in release of nitric oxide and all these things. We know it's in lymphatics. This whole theory has to be proven. But if MLD is the gold standard, and we know that over the course of treatment time with MLD, we get resolution of fibrosis, we get decreased swelling, we get improved outcomes, any pump that does MLD-like action, sequencing patterns, gentle manipulation, I'd love to do biopsies ultimately and prove that it's restoring glycocalyx within the lymphatics, because that's where the functionality long-term comes from, now that we're seeing all this other emerging data, both from benchtop as well as from clinical experiences. So I think anything that replicates standard of care is important, because if you're squeezing too hard on the leg, all you're doing is pushing fluid in subdermal channels that don't have endothelial cells. And if there's not an endothelial cell, there's no way there's a glycocalyx. And we know from studies from other researchers that have done skin biopsies that show massive amounts of fluid going in non-epithelialized, non-anatomic channels. So I think there's really two schools of thought. There's the push hard, the push, or there's the pull, because all tissue is subatmospheric. So if you just get the lymphangions to kick in like a straw, it's going to suck up just that beautiful diagram that you show, the anchoring filaments. It's actually going to kick in that lymphangion function and get the contractility going, which lasts for 4 to 6 weeks or 4 to 6 hours once you get it stimulated. So the whole thing makes a lot of sense.
And Mark, can you just comment a little bit? There was a question on diuretics role.
So diuretics are great for if you've got congestive heart failure, you got a renal issue, you got a hepatic issue. But if it's true lymphedema and all you're going to do is move some water, but you're going to leave the proteins behind, you actually ultimately make the situation worse with long-term diuretic specifically aimed at managing lymphedema. And I think another medication that's so important to highlight, because there's a lot of medications that cause lower extremity lymphedema. One of the most common ones we see is Norvasc or amlodipine. So any patient I see on Norvasc or amlodipine, I'm calling the primary care doc and I'm saying, can we stop this and start an ACE inhibitor or something else to treat their blood pressure? Because we know at least 50% of the people that are on Norvasc, amlodipine will end up with worsening edema over the course of time. And it could be a very idiosyncratic reaction. They could have had Norvasc for 10 years and now they just get swelling. We try to get everybody off that medication.
Susan, how about, we've talked about MLD and maybe this is not maybe this is the next webinar we do, but how about use of wraps and their role and compared to like ACE wraps, like what do you guys use for compression?
So during the bandaging?
Yep.
So we use short stretch bandaging, which is different than your long stretch or your ACE bandage. And the reason why that is with a short stretch, that it does have a low resting pressure, but a high working pressure, which we want to have, because as the patient has their bandages on and they're up and moving and they're walking, as that calf tries to expand and as the muscles try to expand, that kind of resistance from the short stretch bandage isn't going to allow it to just stretch out. It keeps that resistance. And so instead of kind of pushing out during walking, it's going to push that fluid more upwards. Whereas if you used an ACE bandage, you're going to get that stretch. And with an ACE bandage as well, that it does have a high resting pressure. So, which can be uncomfortable for patients, or like Julie said, if not applied appropriately, if it's, pulled too tight or too much stretch applied to it, can really create some issues for the patient as well.
I was just going to say too that the ACE bandages, it's made out of elastic and it can stretch up to 300%, and short stretch only stretch up to 30 to 60%. So you really are getting that main resistance when you're up and active and moving.
Mm-hmm.
And there was another question, Julie. So once you get somebody controlled and you get them the acute phase, you get their swelling down and they're done with their 4 weeks of MLD, you send them home, let's say either with self-MLD or with a Flexi Touch, and they're doing great. Now, you recommend for the patient to continue using their Flexi every day, tapering it down?
I think that depends on the patient, but I mean, they have a lymphatic problem. So they have an increased lymphatic load that isn't going to slow down just because they have reduced their edema. It's going to be an increase in above that transport capacity every day. So in my mind, I think that using a pneumatic compression device really just decreases the lymphatic burden for that patient every day. And also just educating the patient on what their threshold is.
And Mark, there was a question on, you covered a little bit, lipedema and lymphedema. How important is it to distinguish between the two when you're treating these patients?
I think it's really important because there's that merger late stage, but picking up on early stage lipedema, also known as painful fat syndrome, there is treatment. So compression can be very beneficial. I've even heard of MLD being important, decongestive therapy, exercise, stretching, weight modification if necessary. But there's the tough part, because you can literally starve yourself and you're going to lose weight from the waist up, but you're not going to lose it from the waist down. And that's going to be one of the signs that it's actually you're dealing with lipedema. So even somebody who looks like they have lymphedema, I'll start to ask them that questions. And if it's the same answer, I can lose a lot of weight off my torso, but I can't lose on my legs, but they look like lymphedema, then it's probably lipolymphedema. So micronized purified flavonoid fraction, Daflon in Europe, Vasculara in the United States has certainly been shown to be helpful for lipedema. And so I think it's important to make the differentiation, because 99% of the diagnosis of lipedema are women, and they almost always say, well, everybody said I was crazy about the diagnosis. I knew something else was going on. So I think giving the assurances to our patients is incredibly helpful, and we get them the right treatment.
I think one more popped up here. Jules, after you're pretty much done with the patient, do you typically follow them up afterwards when they're done with their 4 weeks, or pretty much that's it?
No, I would have patients come back one more time, and maybe 4 to 6 weeks, just to see how they're doing, and making sure the program that we set up for them is working.
Well, I think,
Just making sure that you really educate your patients. Again, this is progressive, it's chronic, that for them to really be monitoring their signs and symptoms, and if there's any changes, to be reaching out to us, their medical provider, to get on top of it and see if there needs to be a tweak. Maybe something in their home program needs to be changed or updated, or whatnot. So we call it a tune-up. Every once in a while, they need a tune-up.
and Mark, just briefly, how do you diagnose lipedema? What are the classic clinical findings?
You're looking, again, the classic history is I can lose weight off my torso, can't lose it off my legs, multiple family members, pain. My almost 99% are going to be women. And they may say, look, I'm in bed and my husband's hitting my legs, and it's just always painful. So those are the most classic. And then it's foot sparing. So typically you don't see and it goes to it's called a cankle. You get that overlapping at the ankle in really advanced cases. So foot sparing is a pretty significant aspect of it as well.
Sometimes these patients complain of easy bruising too.
Yes, thank you. Excellent point.
So I think at least I've learned more than what I knew to start with. I hope
Good.
everybody else,
Yeah, so have I.
I want to thank the speakers. I have actually a poll question, and I am actually going to share my screen here. Oops. Continue. And oops. So Delphi was located at the temple of, we talked about a Delphi oracle earlier in Socrates. So let's launch A, B, C, or D.
Have you been there, Dr. Xaris? Is that your picture?
No, it's not my picture, but yes, I have. All right. Yep, you're correct. It is actually, yeah, it is Apollo. C. And the next question. What was her name? Julie, you know?
Demetra.
That's what I would have guessed too.
It's
Are-
actually
No?
Thea. So there you go. Actually,
There
people,
we go.
all right, not bad. So we learned a little pathology along with our lymphedema. So I'm going to share the slides again. Thanks. So a couple of things I just wanted to touch base. Upcoming events as far as educational programs. The next event is going to be October 28th on upper extremity, breast cancer related lymphedema. And then in November 5th, me, Steve, Dean, and Tom O'Donnell will be doing our second Venous and Lymphatic Journal Club. So please, you can go out to the website to register or look for soon to come email for these events. And then finally, I want to invite people, if anybody's registered or planning to be at AVLS, and actually you don't have to be part of the AVLS meeting. You can, I believe, participate at the trivia competition that Steve Dean will be doing, and I'll be moderating with him. Please look for that and join us. We'll have some fun on some trivia for lymphedema. And Sue, you want, who's
Oh,
talking?
I was just gonna say that I am part of there's another session right after that, which is the LEAR session, which is the lymphatic and tegumentary rehab section. And it's lymphedema therapists and physicians talking about how they can collaborate more effectively to really provide more comprehensive care for their patients.
Thanks, Julie. I think we're going to call it. We're at a little bit almost 15 minutes past the hour. I want to thank the speakers. I think this was a great session. I think we should do the next one is with some video demonstration of wrappings, and that would be nice.
Okay, good.
Yeah, just compression garment options altogether.
In
I think
general,
it's
right.
really overwhelming for patients and to find something that fits. I mean, I think the biggest non-compliance comes to patients saying they're uncomfortable, they cut in, they bind, and be able to just talk about finding the correct options for them.
Yep, I agree. All right, thank you very much.
Thank you.
Thank you.
Have a good night, everyone.
Awesome.